The other topic I talked about was B lymphocytes, or type of white blood cell, type of lymphocyte called B cells or B lymphocytes. And those cells have now been shown fairly dramatically, if you reduce them by using an anti-CD20 monoclonal antibody, and there are several of them available now. If you reduce the circulating B cells using that particular method, patients who have relapsing disease have a reduction in gadolinium-enhancing lesions. But I want to say that these are not FDA approved right now for relapsing MS, but hopefully maybe one day they will. There are studies going on, including at the phase 3 level now, that have not been unblinded yet, so I don't know the results of them. But if they're positive, like the phase 2s were, then we should expect to have something on the market within a year or two. Well, we don't really know how they work exactly, but probably they work very fast. We do know that, at least on the MRI, and so within a couple of months. So they have a drastic effect on the MRI activity based on gadolinium-enhancing lesions, and so probably they act through methods other than their eventual production of antibodies, or differentiating into plasma cells that make antibodies. And by the way, the anti-CD20 molecules do not affect plasma cells because they don't have CD20 on their surface. They probably act through antigen presentation to T cells, because T cells are also very important in MS development. So it probably blocks activation of T cells by blocking the antigen presenting cell, the B cell. And then also B cells make several factors which are involved in inflammation and the development of ectopic lymphoid tissue that has been seen by many pathologists in secondary progressive MS, in particular in the meninges and sometimes in the brain itself. So the B cells may be very instrumental in the development of those ectopic lymphoid follicles, which are thought to be bad. They're associated with cortical demyelination. I think it would give us another very strong agent. It's likely to be intravenous, although one of the anti-CD20s can be given subcutaneously, so the patient could give it themselves. So I think it's going to just add to our armamentarium that we can use in patients, and this is a particularly strong agent that acts very quickly, so that could be very useful in some patients. I think probably when you get to the level of these monoclonal antibodies, most of the patients are going to be prescribed these by MS specialists or neurologists who see a lot of MS and feel comfortable with them, because they often have risks associated with them and lots of monitoring requirements. So somebody who's really familiar with the medications probably ought to be prescribing them, unless you're in a remote part of the world and you don't have any choice and you're a primary physician. But even then, I mean, you can work with neurologists who are available by email or phone. It would be in addition to the current therapies, because there's nothing that it would actually replace, and we don't want to get rid of any of our therapies that we have. We want to have as many options as possible.